Thank you very much. Today I'm in Hong Kong, which is a real pleasure. So highlights in hepatology, past, present, and vision for the future. I want to give acknowledgement to all the past and previous members of our institute and also to all the collaborators. And I have a lot of disclosures. I work with all the companies in the field. Networking is something that Dr. Reddy also mentioned. And I think networking in research is a must these days. And so I would like to give credit to all the networks that we take part in. I'm at a medical school that was founded in 1965. And it's very important that nowadays, in order to achieve major public funding, that medical schools focus their efforts on 3 to 5 areas. Our 3 areas are infection, immunity, and inflammation research, transplantation and stem cell research, and biomedical engineering and implants. Our department is involved in the first 2 areas. I would like to start with transplantation. We, as hepatologists, we have the major task to avoid transplantation, that our surgical friends don't have to work all night. So having a transplant primarily is a defeat. Nevertheless, Hanover is Germany's last transplantation center, and when you calculate liver, kidney, lung, and even bone marrow, we are on the top of the list in Germany. The challenges in transplantation medicine are various, and one is chronic transplant failure, tolerance and rejection, and we want to achieve tolerance in the future without immunosuppressive drugs. We have to prevent infections, recurrence of disease. We have a problem of an increase in donor age. And then we have organ shortage. In Germany, we have half as many organ donations per million population than in Spain. And finally, we need to find alternatives to classical organ transplantation. Dr. Reddy has shown you that the endoscopic devices did not change over recent years. The same as taking out an organ, a diseased organ, putting in a cadaveric organ has also not changed over the last decades. And we have to think of innovations. So what is the big problem we have? You know, in Germany, this is a terrible publication by Dr. Weissmüller, Dr. Strasbourg, who were at that time still at our institute. In 2006, we introduced the MELD system. The idea was to prevent patients from dying on waiting list in order to giving priority to the sickest. MELD is a score coming from the United States based on INR, bilirubin, and creatinine. But this led to the phenomenon that the sickest were transplanted first, which have the least chance to survive after transplantation. So what you see here, if the MELD score is above 30, then survival after transplantation dramatically drops. So after introduction of the MELD score in our country, mortality was shifted from before to after transplantation. So this is a problem we have to deal with. And then we have another problem. We have the so-called transplant scandal in Germany, that some centers manipulated the MELD score. They crossed dialysis for patients that were not dialyzed. They mixed blood samples and achieved high creatinine levels. At the end of the day, people did not trust in the system anymore, and organ donation dropped by 25%. So there is something we have to work on. The other is increasing of donor age. When I was lecturing in Miami, I was listening to the surgeon, and he reported on the origin of death for cadaveric donors. Number 1 was shooting. In Germany, it's not shooting, it's cerebral bleeding. What is the other problem? Everybody asks in Germany why it's so easy to drive fast cars. It's easy to drive fast cars, but it's not easy to drive fast with fast cars because the roads are so congested. So we don't need a speed limit. This is the reason why our road accidents and mortality is continuously decreasing over the years. So donor age is increasing, and also recipient age is increasing. Years ago, people were thinking liver is not aging, but liver is aging. Older donor livers have, for recurrent hepatitis C, a more rapid fibrosis progression. So now recurrence on disease. Due to the limited time, I cannot touch everything. But recurrence of disease, there we have to really present success. Here is our center's data. This is various diseases after liver transplantation. And you see among the best indications is hepatitis B. This is new. In 1990, the late Dame Sheila Sherlock wrote an editorial in British Medical Journal, and the statement was hepatitis B is a contraindication for liver transplantation. Why? All the patients had recurrent hepatitis B, 50% died after 3 years. Now, with the new drugs available, we can prevent reinfection after liver transplantation, and B, being once the worst indication, is now one of the best indications. What is now with hepatitis C? Hepatitis C is the worst indication because reinfection of the graft is, or I must say, has been universal, and fibrosis progression is very rapid. However, due to the new drugs, the new direct-acting antiviral agents, we know if the virus is not detectable 30 days before transplantation, we can prevent reinfection. So in principle, reinfection does not occur anymore. So prevention of HCV recurrence is possible. However, this study I showed you before was a specific patient population. These were patients with liver cancer, which had compensated child A cirrhosis within the Milan criteria. However, the normal non-cancer HCV patients is far more advanced, has decompensated cirrhosis, and therefore we still have to work on these particular patient groups. However, cure of recurrent HCV post-transplant is also possible now. So the question for HCV is, can we prevent liver transplantation due to hepatitis C? And what about decompensated cirrhosis? I'm sure in 10 to 20 years there will be no transplantation for hepatitis C anymore, but for that we need to be able to cure advanced liver disease. This is a study presented 6 weeks ago at EASL, treating decompensated liver disease, and the majority of patients, you can improve the Child-Pugh score. You can recompensate liver disease, but a minority of patients, their disease is too much advanced. Those should not be treated before transplantation. If transplantation is, we can treat after transplantation, but we have to acknowledge that transplantation is not an option in all parts of the world. So an urgent, unmet need is defining this point of no return when it is still reasonable and profitable for the patient to cure HCV. The outlook is bright, and I really foresee that HCV is not an indication for liver transplantation in the future. The final issue on liver transplantation is that I think we have to think of alternatives in order to reduce shortage. And for example, if you have a genetic liver disease where only one of the 2,000 genes is deficient, we go, for example, in Wilson disease, we take the diseased liver out and we put a new liver in. But we would only need to replace one gene, which we are already doing in hemophilia. So the idea was to do hepatocyte transplantation, not taking a whole liver, losing liver cells. And there are 3 major disease classes: acute liver failure, genetic liver disease, and liver cirrhosis. Certainly liver cirrhosis is the worst and the most difficult part because a cirrhotic liver with all the consequences for the health system and the architecture of the cardiovascular system and the vascular system in the abdomen, we should first try to develop these technologies for acute liver failure because the high regenerative level of the liver and genetic liver diseases where we only need to replace one function. Something which plays into our direction is that the liver is a highly regenerative organ, and therefore the high functional reserve of the liver can be used, in particular to use this technology for inborn errors of metabolism or acute liver failure. The question is, should we work with adult hepatocytes or should we use stem cells? And there is animal work that gives arguments to use primary hepatocytes before using stem cells. However, here is basic research investing a lot of efforts, and hopefully we come up with solutions that can use in clinical practice. We collaborated with a company called Cytonet and developed a procedure of human adult hepatocyte transplantation. Dr. Michael Ott is heading that group, and we already treated some patients. We have the largest experience in Germany, and set up the first program in our country, and you see a patient with Amanita fungi intoxication that she could be saved from hepatocyte transplantation. Unfortunately, the trial for acute liver failure had to be stopped because all the first 6 patients died. The reason is we could only enroll patients in the trial that were not eligible for conventional liver transplantation, meaning all the patients had a MELD score above 40, so nobody would survive, even not with conventional liver transplantation. So if we explore innovations, we must have a chance to give the procedure a fair chance. Another approach is doing genetic liver diseases. And out of our work came a multi-center study headed by the pediatricians in Heidelberg. We were contributing is to use one particular genetic liver disease, and this is a liver disease of children. These are urea cycle defects, and there are 3 different enzymes that their deficiency may lead to severe hyperammonia levels threatening the patient. And this is a study which is almost completed. The approach has received orphan drug status by the European authorities, and this will soon be approved. The hepatocyte transplantation will soon be approved, I hope, for this particular genetic defect of the liver. Genetic liver disease, as you can imagine, is a numerous collection of diseases. I always would like to state that cardiology is very easy. You have a muscle contracting, and you have 3 diagnoses that you have to treat: the 1 vessel, the 2 vessel, and the 3 vessel disease. Liver diseases are much more complex. If you look at genetic, you can have gene defects in the liver leading to liver disease: Wilson disease, alpha-1 antitrypsin, cholestatic liver disease, familial hypercholesterolemia, cystic liver. You also have gene defects extrahepatic leading to liver disease, like hemochromatosis. And you have gene defects in the liver leading to extrahepatic mobility, like familial amyloidosis. There's also a program. The familial amyloidosis, a pathological protein, is synthesized, deposited in the cardiac muscle, in the brain, in the neurons, in the GI tract, and they die, these patients, in the age between 40 and 45, and there is a program taking their liver and giving it a 60-year-old cancer patient while saving the patient's life by giving him a cadaveric donor liver. This procedure is called domino transplantation, and there you can really save 2 people instead of 1. I would like to give you some very few aspects on genetic liver diseases. And this is, when I started hepatology in the 70s, all the stars in hepatology were doing research in bilirubin. They were transporters. They were all bile acid researchers. But somehow in the 80s, they disappeared from the scene. But when molecular biology took off the ground, they came back because they had identified the transporters of all the important components of the bile. This is bile physiology. What is also interesting is that several of the genetic inborn errors of cholestasis, that they are due to molecular defects in these bile transporter proteins. One example is MDR3, others is BSEP, or the other transporters of bile acids. This is also a genetic liver disease, cystic liver disease. And when I started in 1991 in Hanover, you have to give always, by German tradition, an introductory lecture. And the surgical partner at that time was Rudolf Pischelmeier, a worldwide pioneer in liver transplantation. He was sitting in first row, and I said, Professor Pischelmeier, it will be a pleasure for me working with you, the first gene therapist in the world. He said, why? I said, the only functional gene therapy is organ transplantation. The only thing is that the surgeons don't know about it. And imagine, this is a genetic disease of the liver. If you exchange the organ, you replace the gene, and so you are doing gene therapy. Now I turn to viral hepatitis. Viral hepatitis is an enormous threat to the globe. We discussed this morning, and I want to be very, very brief. 5 different viruses discovered by 5 different individuals and their team. Chronic hepatitis C is a curable disease. Viral elimination does prolong survival. And I think that hepatitis C, which has come to some conclusion now, has been a masterpiece for translational research. We saw a discovery of the virus, we saw the replicant system to develop the drugs, and we see now the direct-acting antiviral agents. And while in the 90s, the most cited papers were dealing with Helicobacter pylori, it's now hepatitis C. And almost half of the top cited papers in our field now come from hepatitis C. This will change in the future, but this is now the time of hepatitis C. This development led to cure of hepatitis C to up to 100%. I'm still waiting for the paper describing more than 100% cure. I'm sure somebody will be able to do that. We have currently several and many drugs available. We discussed them this morning in detail. We have various regimens, and certainly we will use these regimens, and we may use different regimens in different parts of the world. However, there is still competition in this area. Pharma still thinks that it's worthwhile investing in this disease, and so we have additional combinations available, and still billions are spent to acquire companies and drugs and patents. And there, just a publication a few days ago that the big pharma giant acquired a small pharma innovative company in order to be competitive in hepatitis C. So hepatitis C direct-acting antiviral agents are or will be efficacious and safe in all HCV-associated liver diseases. So the prospects for hepatitis C eradications are as follows. We have and will not have a vaccine available. However, we can cure by medical therapy. We can do this interferon-free. Access to these therapies is a major global threat. Costs are a main challenge to increase treatment. And for the time being, we will need regional solutions. However, these regional solutions, hopefully, will change the scenario of today where we still have new infections, where we have a low rate of cure rate in many parts of the world, and we still have significant mortality. If we prevent new infection, and this includes having safe blood units all over the world, we need to increase the cure rate and stop mortality, then we will hopefully eliminate hepatitis C in the future. Companies nowadays and researchers like ourselves are on the way to leave hepatitis C and to go in hepatitis B. And we can stop progression of hepatitis B, but we cannot cure hepatitis B. And therefore, we still have to work on technology that interacts with the cccDNA in order to use finite durations of treatment and hopefully cure hepatitis B. At the last liver meeting 6 weeks ago at EASL, we have seen some interesting contributions tackling, again, different aspects of the life cycle. There is new technology, the CRISPR-Cas technology, which is able to tackle cccDNA, and there has been a very important paper, Science 2012. The senior Emmanuelle Carpentier is now professor at our medical school, and everybody is hoping that she gets the Nobel Prize pretty soon. And famous virology laboratories like the one of Charlie Rice are already applying this technology for future hepatitis B therapies. So hopefully, all the different approaches for future therapies of hepatitis B will lead to cure. Nevertheless, the bar is high because new therapies have to be safe. The present NUCs are safe. They have to be easy, accessible, low costs. Application should be easy, ideally as oral treatment, and endpoints need to be defined as cure. Nevertheless, and this slide is from Markus Kornberg, we will see surprises in the development of future therapies. So maybe as researchers, we should not choose a bar which is too high. So a lower bar is hepatitis D, delta. We still have 20 million or more hepatitis delta patients. NUCs have no effect, interferon only effective in 30% of patients, and late relapse occurs. There's fast progression of liver disease, and just the EU, EMEA, has accepted delta as an orphan disease. And we have high diversity. Delta, as you all know, is an RNA virus that uses co-infection of hepatitis B, which provides the surface antigen. And it is a worldwide disease. In some areas, the disease is decreasing, like in Italy or everywhere where vaccination programs are in place. But in some areas, disease is increasing, like in the Amazonian basin in Brazil. The only efficient treatment is interferon, but it's only working in 25% of patients. But at the last liver meeting, luckily, we have seen different approaches specifically tackling the life cycle. One is Mirclodex, preventing uptake of the virus, and prenylation inhibitors. Dr. Klenn founded a company, and you really can see that the decay, which we first saw some weeks ago by prenylation inhibitor lonafenib, is much more significant than we have seen with interferon-based therapies before. And therefore, we founded the Hepatitis Delta International Network, founded by the German Center for Infection Research, where everybody can contribute, and we are offering this network for developing new drugs. The last hepatitis virus is hepatitis E. So hepatitis E in Europe is not the major disease which is distributed as acute hepatitis. Hepatitis E may be the cause for the most prevalence of acute liver failure. In Europe, we have another genotype, and it may be distributed to meat. We have seen that in Germany more than 100,000 HEV infections occur de novo, 70,000 deaths occur worldwide. Hepatitis E assays are variable and need to be standardized, and chronic hepatitis E runs a progressive course. This is late information coming from France, Sweden, and Germany, that in particular in immunosuppressed patients, post-transplant, we see a rapid progressive chronic hepatitis E that we have not seen before, and hepatitis E also is more than a liver disease. Therapy, we have used ribavirin so far, and nevertheless, at the Global Hepatitis Summit later this month, EASL, European Liver Association, will sponsor a e-symposium dealing whole day with hepatitis E. The last part I would like to cover is autoimmune liver disease. We have three types of autoimmune liver disease: autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis. I cannot go into detail into all these diseases, but nevertheless, the liver is a model also for autoimmune diseases. Most rheumatologic diseases are autoimmune diseases. In liver, autoimmune diseases are rare. Nevertheless, we can access the target organ, the liver, and we can do studies and animal models that in rheumatology are impossible. Autoantibodies are one part of the hallmark of diagnosis. The autoantibodies are very heterogeneous, like antinuclear antibodies, and a number of autoantigens have been discovered in the last 2 or 3 decades, applying molecular approaches like molecular cloning, and the number of antigens has been identified at the molecular level. One of the interesting ones are liver-kidney microsomal antibodies, and they target one enzyme which is expressed in the endoplasmic reticulum and on the surface of the liver cell, and these are the epitopes, and you see that some of the epitopes in one particular has sequence homology with a viral protein, the herpes simplex virus. The standard of care has not changed since 1951, when the disease was described first. Prednisone alone or in combination with azacitidine. However, up to 80% of patients, in particularly the mostly affected young women, experience corticosteroid side effects. So one innovation is to use a topical steroid, budesonide. And this clearly has been shown that budesonide is able to induce remission, maintain remission, without corticosteroid-specific side effects. And when we switch from prednisone to budesonide, we really can ameliorate steroid-specific side effects. This is a minor progress. We hope major progress we can achieve when we further unravel the pathogenesis of autoimmune hepatitis and more specifically intervene with the molecular pathogenetic pathways like interfering with TNF or with the B cell with rituximab. And this is something I would like to end with. that now we use TNF antibodies, which is beneficial in those not responding to standard of care, and also with rituximab inhibiting and destroying beta cells. The final goal, however, as I mentioned before, is that surgeons don't need to work all night, that we should cure all patients with autoimmune hepatitis before they lead to transplantation. This is the last slide that I would like to show you. And this is, we have solved a lot in recent years, but there are still diseases where we have no idea about the etiology, no idea the physiology, and have no treatment apart from transplantation. And this is primary sclerosing cholangitis, which is really the next challenge of the future, but this is for generations to come. Thank you very much.